Well, thanks again, everybody, for being here. Our theme this year, the Care for All, this session is about access, barriers to care with Dr. Constantinos Tselios. Many of you know him. He's a well-known figure within rheumatology in Canada, in Ontario, and with Lupus Ontario. He is the assistant professor with the Division of Rheumatology, Department of Medicine at McMaster University in Hamilton, and he's establishing the Lupus Clinic Registry and Biobank at McMaster. The project was approved by the Hamilton Integrated Research Ethics Board and aims to collect demographic, clinical, laboratory, and therapeutic data from patients with systemic lupus erythematosus attending the clinic on a longitudinal basis. In parallel, biosamples, including serum, plasma, DNA, and urine from the patients will be collected and stored in the Lupus Ontario and Matheson Biobank to facilitate basic and clinical research in the field. Additionally, Dr. Tselios pursues multifaceted research related to disease activity during the course of systemic lupus erythematosus, SLE, the impacts of lupus nephritis, LN, as well as drug-related interactions impacting quality of life. Dr. Tselios has been a two-time Jeff Carr Fellow, and we are very grateful for all the work he does with us. I forgot to introduce myself. I'm Lisa Bilodeau on the board of Lupus Ontario, and I really appreciate and look forward to what Dr. Tselios is going to be sharing with us today, focusing on challenges in finding a rheumatologist, challenges facing rheumatologists, challenges around treatments, and access to treatments, including biologics. Thanks so much, Dr. Tselios.
Lisa, thank you. It's my pleasure, actually, to be here with you today and discuss about the barriers to care that lupus patients face on a daily basis. I think we, as physicians, we haven't paid enough attention to that. And I will explain this with a few slides. So we'll try to finish on time. What I want from you and the attendees, and thank you all for spending your Saturday here, is to be involved, to be engaged in the discussion, and maybe provide some clues, some ideas on what we can do, not only the physicians, but also to like other levels, like even government levels of to help the lupus community. So we'll discuss this. These are my disclosures. Let's try to imagine, like most of you know what you went through, what the journey of the lupus patient is. I don't think that rheumatologists, the lupus specialists, are fully aware of this, and we come at some point in your journey. So when you will develop symptoms, you will go to your family doctor, most likely. For you who have a family doctor, you will have some tests, hopefully. Sometimes you will struggle to convince them to order some tests, and then you will come, hopefully, to a rheumatologist, and the rheumatologist will make the diagnosis or will confirm the diagnosis or something like that. In any case, they will prescribe some medications, and then if everything goes well, you will continue seeing them like lifelong and getting advice from them. Is this what is always happening? No. For a great proportion of the lupus patients, this is like a very, very simplified journey. Back in 2009, the Canius investigators, Canius is a group of rheumatologists with particular interest, special interest in lupus. Lupologists, we call themselves anyway, but in any case, rheumatologists in general with a particular interest in lupus. And they have a collaboration and the common research protocol. This goes across the country from like all provinces, almost all provinces. So they had a survey of about 700 patients, if I'm not mistaken, on exactly this, what we perceive, both from the patient's perspective and the physician's perspective, what we perceive as barriers in care. About 55% of the responders actually said that they had at least one barrier. And the rest, 45%, they said that there was no problem during my journey, or like some difficulty or anything like this. So from the patient's perspective, the main problem was the cost of medications, about 1/3, the traveling time to rheumatologists, and I guess the expenses that come with this. Waiting to see a rheumatologist, our waiting times are horrible. I know we'll discuss about this in a few minutes. Access to medications, there was not a significant issue back then. Why? I think because we didn't have the new expensive medications in 2009. We didn't have the belimumab, we didn't have anifrolumab, and the cost of the traditional medications we were using at the time was not so high. Cost of medical devices. If you go to the other end of the relationship, this patient-doctor relationship, the physician said that sometimes they had some language barrier, some missed visits and non-attendance to clinic. We'll discuss about this. Access to medications was not so high, like 4.4% of the physicians reported that, and then non-adherence with medications. I'll say a few things about that. So let's go to the primary care. Why we'll go to the primary care? Because the Canadian system is built on the primary care and the relationship between the patient and the primary care physician, the family doctor, as we call them here in Canada. Based on the Canius survey back in 2009, they had like 654 patients. 88% of them reported that they had access to a general practitioner in their community, and that's great. We're doing really well. Almost 90% will have a GP. 80% of them, slightly less, had a GP who could see regularly, who they could call the office and get seen in like a week or 2 or 3 or something similar. Anyway, some timely access to primary care. What is happening now after 15 years? Did we get any better? Not much. I would say there was a survey from 2023, national, across Canada. More than 9,000 patients responded to that. And they found out that about 21% of Canadians, or an estimated 6.5 million actually, they did not have proper primary care. We're not doing so bad in Ontario. We're talking about 13% of Canadians Ontarians without access to primary care. 27% in BC, 31% in Quebec. So it's still an issue, right? The access to primary care, and who will you call if you have any problems in general, not only for lupus, but particularly for patients with lupus or for patients who might have lupus. They may get problems with accessing a physician. What are these patients going to do? Most likely they would attend a walk-in clinic or an emergency department in Hamilton or elsewhere, and they will not get any significant, any important answers to the problems from the walk-in clinic. Most likely they will be prescribed some painkillers or some anti-inflammatories. Sometimes we get referrals from the walk-in clinics. Why? Because the patients know, or they have talked to somebody else, and they will ask specifically for this, like send me to a rheumatologist, please. And if the doctor there, the physician there, agrees with this, they might send a referral. If they go to an emergency department, the emergency physician is not equipped, is not supposed to do this. They will not refer patients to the rheumatologist. They are there to handle the acute problem, and then the patient will go like elsewhere. What is happening if the patients go to the emergency departments, or they go to walk-in clinics and then they will go again and again, or even if they go to the primary care physician, the family doctors in general? This is a survey from the States. Actually, they asked 827 patients, and the questions were exactly this, like how long did you take to get a diagnosis? How long did you take to go to your family doctor? And all these things that we are quite aware of in Canada. We know these numbers. Actually, there was like a delay of 2 years on average from symptom onset, from the first symptom, to seeking medical assistance. Why this is happening? We don't know exactly why. We can speculate. Our patients are mostly young for the disease onset, and when they have symptoms, the symptoms might be mild. By mild, I mean some rashes that come and go, some pains in the joints that come and go. The mean age at onset is like 30, 31. At that age, and mostly, of course, women, 90%. At that age, women have other priorities. This is what I'm telling them. They probably have other priorities like career, family, studies, other things. They don't pay attention, or they can push through this because they have reserves, right? When you're 25 years old, you have like reserves to push through this. Anyway, we'll have this delay of 2 years from symptom onset to seeking medical assistance, and then another 3.5 years from seeking medical assistance when you have gone to a healthcare provider to diagnosis. Why this is happening? We said about the disease of 1,000 faces. We said about no two lupus patients are the same. We said about the fluctuation in severity of symptoms, and then the patients might feel better when they come to the family doctor. And of course, the question is, if they go to the family doctor, if they will not be dismissed, or if they will have the blood tests that we use to diagnose lupus. And this is happening quite a lot. Actually, about like 63% of the patients were misdiagnosed, and the 75 from the primary care physician. This PCP stands for primary care physician. So the majority of lupus patients will receive a different diagnosis from the get-go. And if the diagnosis is like close, say an autoimmune condition or undifferentiated autoimmune condition or lupus-like disease, we'll get to a rheumatologist, and then we'll get something more specific. If it's something totally different, like fibromyalgia, for example, or what I'm getting from my patients when I first see them is that like many physicians disregarded the symptoms. I know it's annoying, but it's happening, and it's still happening a lot. On average, these patients, the 827 Americans that responded to the survey, they said that they saw 3 healthcare providers, 3 different doctors, 3 different physicians before they received a formal diagnosis. And of course, this takes time. If you take into account the waiting times and the delays from one specialist to the other specialist, or from the primary care physician to the specialist, it takes a lot of time. Why this is happening? I don't want to bother you with this. I really don't want to. This is for me only, and for other interested physicians. Why this is happening? This is happening because I will see you, and the other rheumatologist will see you most likely when you have started accruing damage from the disease. And this is very late in disease onset. What is happening, what we believe is happening now, is that in genetically predisposed individuals, like you have some genes, they come from your mother or from an aunt, from somewhere anyway, you will have like the impact of environmental and hormonal triggers. This may be the ultraviolet radiation from the sun, maybe viruses, maybe bacteria, maybe drugs. And this interaction will lead to some breakdown, we say, of immune tolerance. What this means? Your immune system has mechanisms to regulate, actually kill, in layman's words, cells that do not behave. Cells that do not behave are generated like every day in our bodies, like even in non-autoimmune patients, in people, in persons who don't have any autoimmune condition. What is the fate of these cells? These cells will be killed by other cells of the immune system that patrol the area, and they check them constantly. This mechanism is disrupted in lupus. So the bad guys will survive. And if they will survive, they might get more and more. And then at some point, they will start producing, like making trouble. And by making trouble, I mean making antibodies or some other proteins. We call them cytokines, okay, whatever. But in any case, they start causing trouble, and they start causing inflammation, chronic inflammation. At that time, you will start feeling unwell. What this means, you may start having visible symptoms like a malar rash or some arthritis like joint swelling or pain, or invisible symptoms like fatigue. And the symptoms may fluctuate. Why it may fluctuate? Because we have cells in the immune system that will still regulate the bad guys. So this relapse and remitting course that I showed like in a publication about like 2 or 3 years ago, I don't remember, is not only happening after this is diagnosis, it's happening even before. And I'm sure that most of you will remember that your symptoms were fluctuating and we don't know why this is happening. We say, I suspect some immune regulation mechanisms. And I'm thinking of this, I would like to have a grant to study this. It may depend even from the weather. We know now that changes in the weather and the humidity in the temperature may cause like full-blown lupus flares. And we have shown this in a publication like 3 or 4 years ago, a collaboration with the California, some colleagues from California. But in any case, what I want to keep from this is that when you come to me, when the diagnosis is made, there's like many, many years before that the disease has started. So I would like to say this as the onset of clinical disease, not even clinical disease. Clinical disease will start like here. And this is diagnosis. How do we know this? We know this for 20 years now. And we're trying to find ways not only to predict, but also to prevent disease from happening, or anyway, minimizing the impact of the disease. This is from the American Army, the US Army. When you get like enrolled in the US Army, you give some blood. And they store these samples for many, many years in deep freezers. And they had the soldiers and everything. Some of the soldiers developed lupus, like after like 4, 5, 10 years from the recruitment. So they went back. They took the stores, the samples out of the freezers, and they checked for lupus antibodies. And they saw that some of these antibodies, and like well-known antibodies, like the anti-dsDNA, for example, highly specific for systemic lupus erythematosus, were present in about like 20, 40, even 60% of these patients, up to 5 years before something started. Before the first manifestation, for example, of the disease, they had antibodies. So we know that something is happening way before I or the other rheumatologists will come into the game. And this causes trouble to the prompt diagnosis. Okay, so we're past this. Now we got to the GP. The GP did the tests. They send you to the rheumatologist. Well done. You're in the hands of a specialist. How many of the lupus patients in Canada have a rheumatologist? About 92%, according to the 2009 survey. More than half, 55%, had to travel to another community to see the rheumatologist. And they consider this to be a significant barrier. Why? Because they had to pay for that. And they not only have to pay for that, but also skip a day of work, make arrangements with family, make arrangements to have a driver, some of the lupus patients, and all these things that come to play. And we as physicians don't even think about it when we see our patients. How many rheumatologists we have in Canada? 417, according to the Canadian Rheumatology Association, 354 for adults, 63 for the kiddos. Is it an adequate number for an estimated 37,000 lupus patients in Canada? We say like 1 in 1,000. We estimate about 37,000 lupus patients in Canada. So we should be seeing about 100 lupus patients per rheumatologist. Is this happening? No, it's not happening. Most rheumatologists do not see many lupus patients. Anyway, they have just a few. And this is happening because of the complexity of the rarity of the disease, and because many of the lupus patients will end up with some other specialists, with nephrologists, with neurologists, with cardiologists, or if the disease course is mild, they might get and followed by the family doctors. Okay, so you have like a rheumatologist. Your journey ends here. What do I mean for this? We have developed like lupus clinics in Canada, and we have like great lupus clinics and the Toronto Lupus Clinic. I was there, and I'm glad to see Dr. Semalulu. We had her in Hamilton McMaster as a resident, and I'm glad that now she's a fellow and she will have further training and expertise in lupus. So general rheumatology or lupus clinic for the lupus patient. There are some studies, actually, and this comes from data, it's not like I'm not making this up, that there is significantly better quality of care in lupus centers, in lupus clinics. What aspects in particular? One, drug counseling and general health counseling, even sunscreen. It was like significantly better. Patients were getting advice and patients were more aware of this in the lupus clinics compared to patients who were followed by general rheumatologists. The use of steroid-sparing agents, by steroid-sparing agents, I mean all these immunosuppressives that we use, sometimes only to get down with prednisone, to go with lower doses of prednisone, or even like without any prednisone. Why do we need to do this? Because we have seen that the damage that comes from the disease, actually, it's like 50% from disease activity, and the other 50% comes from the steroids. So as our patients grow older and they get, say, high blood pressure or osteoporosis or a vascular necrosis or 50% of that comes from the steroids and not from the disease per se. So we're trying to treat the disease at a cost of damage from this. Anyway, now we have like the immunosuppressive, we have two biologics in lupus, and we're very happy about this. We'll talk about this in a minute. What else we do in lupus clinics? We do cardiovascular risk assessment. By cardiovascular risk assessment, I mean we check the lipids, cholesterol, and things like this. We check if the patient will develop diabetes or anything. And we are more sensitive to cardiological symptoms, say some chest pain, some palpitations, things like this. Why we do this? Because we know for 40 years now, actually, it's not something new, that lupus patients are high risk of developing like cardiovascular complications, heart attacks, and things like this. And I have shown, we had a study from the like province-wide, and we published this about 2 years ago, that the cause of death, the primary cause of death in lupus patients is still cardiovascular disease, like heart attacks and strokes. And this comes from the atherosclerosis, cardiovascular risk assessment being done regularly in lupus clinics. General rheumatologists don't have the time maybe for this. They're not so sensitive to this. But anyway, most likely you will get like a higher quality of care in lupus clinics. Osteoporosis screening, okay, like we have the modalities and the tools in place to screen regularly for osteoporosis. Why? Because of the steroids again. And then damage accrual, I told you about this. 50% comes from the disease, 50% comes from the steroids. We are trying to have a balance actually between this and minimize the damage to our patients in the long term. What I would like to stress about this, quality of care was associated with the number of lupus patients seen. What this means that if a rheumatologist, for example, has plenty of lupus patients and follows plenty of lupus patients, there's no like specific number for this, they will gain experience. They will gain experience and expertise with time. And there are rheumatologists out there that have been trained not only in the Toronto Lupus Clinic, but in the States as well, who have like great experience with lupus patients. These rheumatologists had the same outcomes as lupus clinics. So it's a matter like of training, you gain expertise by training. How many lupus clinics we have in Canada? Do we have enough? I don't think we have enough. We have the Toronto Lupus Clinic, and it's great, fantastic. Like I was there for 6 years. I'll always be like a Eurowitz kid. I'm trying to establish something similar in McMaster in Hamilton now, and we are growing by the day. I'm glad to report that we have considered now more than 300 patients. We started collecting the samples in the biobank. We have like more than 80 samples now, and we get like, I think by the end of the summer 2024, we'll be up to 400 for sure. So I know that we don't have something similar, say, in Ottawa. We don't have something similar in BC. They don't have like an organized lupus clinic. They have lupus specialists like in Calgary. They have lupus specialists in Montreal. I don't know what's happening in the East Coast. But anyway, I don't think that we are there yet. We're trying to do collaborations. I'm trying to develop programs for training of the young rheumatologists, the residents. Right, we'll get there, but not yet. We are not there yet. I would like to say a few things about the cost of medications. This is the most important thing, and this is what everybody talks about now, particularly with the new biologics. This is the annual medication cost for hydroxychloroquine. You know, I'm not using trade names. I don't like it. But anyway, Plaquenil, if you don't remember, it's a big word, hydroxychloroquine. If you're taking 2 tablets a day, this is the most common dose anyway for lupus patients. It costs about $2,000 a year in Canada. Prednisone is inexpensive. Azathioprine, the Immuran, okay. The methotrexate, okay. Mycophenolate is expensive for the lupus patients who use this. Azathioprine, methotrexate, and mycophenolate combined are being used for about 40 to 50% of the patients. Right, and going to go to mycophenolate, it's like a significant expense. And then the new biologics, belimumab, since 2011, we have it in Canada, and anifrolumab for the last couple of years. They cost a lot. And this is indicative. Belimumab may go above this number. Why? Because it goes by the weight. Anifrolumab, not so much. But anyway, the numbers are huge, like $22,000 a year for this patient. And both biologics are only covered by private insurance at the moment. What's happening in Greece? I was surprised when I came to Canada. That was my first huge surprise. Right, why people are paying so much for the medicines. For example, hydroxychloroquine in Greece, the annual cost is $65. Right, I don't know why we need to pay more than $2,000 a year for a drug that we have for 60 years now. It's available for 60 years, no patents, no nothing. So why we need this huge amount of money for the patient with lupus? And patients with lupus are taking hydroxychloroquine in about 80 to 90% of the cases, and for many, many years. If we consider an average say of 20, 25 years, we're talking about $40,000 to $50,000 only for the Plaquenil and nothing else. Even the biologics are less expensive in Greece. For the belimumab, we're talking about 1/3 of the price. Anifrolumab, more or less the same. This is converted from euros to Canadian dollars for your convenience. I did that this morning. Okay. What are we doing for the new expensive medications? Okay, tell me, okay, Dr. Tselios, you're doing research, you're doing you advocate for lupus patients. Have you done anything? What are you trying to do for the expensive medications, and if it's worth it? We had, most of you know that we submitted the clinician input. This is a document of about 15 pages, if I'm not mistaken, and the patient input from the board of Lupus Ontario last September. Anyway, the Canadian Drug and Health Technology Agency, CADTH, approved for the very first time public reimbursement for both anifrolumab, the Safnello, for non-renal, non-neuropsychiatric lupus. So we're talking about mainly skin and joints, and belimumab, the Benlysta. You know that for lupus nephritis, only I should have added this here, in December 2022. That was fantastic, historic day, in my opinion, for the lupus community. What are we doing 1 year, almost 1 year, more than 10 months after that, the current state of affairs? They negotiate the price. And when we say they negotiate the price, now the manufacturers, AstraZeneca and GSK, respectively, are negotiating the price with the government, the federal government, for the price. Is it possible that the Canadian government will pay $22,000 a year for Safnello, Benlysta? No. They will ask for a generous discount. I don't know. I don't have any more information about this. They say that we may have an outcome, a response, a verdict after the holidays. So we expect this, and I think that this will help a lot. So, like lots of money, right? Can we afford the medication cost? From a survey in the States, actually 22% were unable, 1 out of 5 were unable to cover the cost for the medication. What this means that these patients will not only go to the expensive ones, to the biologics, but they are not able to cover even the hydroxychloroquine, the black one. This means that these patients will be treated, one, with prednisone alone, because it's the cheapest medicine we have. Two, they will take no medications at all. And they will go from flare to flare to flare. They will keep accruing damage. And then, of course, they will have more renal disease, end-stage renal disease, or they will even die. What's happened in Canada? Slightly worse, 10 to 7.5% report that the cost of medication was a significant barrier. In Black patients, you hear Dr. Semalulu before, we're talking about 40% of the Black patients not being able to afford all the medicines. And as if it wasn't enough, we're talking about an annual direct cost for a lupus patient of $33,000. This comes from both the States and the Canadian study from Alberta. Dr. Clark published this in 2016. We're talking about 33,000 Canadians per year. And an indirect cost, lost productivity, I will say a few things about this, anywhere from $1,000 to $20,000. Anyway, they estimated a $50,000 annual cost for a lupus patient without renal disease. When it comes to renal disease, we're talking about 100 easily. 55% of the patients with lupus reported loss of income due to lupus complications. Not only from disease activity, it's not only disease activity. We're talking about complications like I gave you steroids, you developed a vascular necrosis of the hip, it didn't go well, and you needed to have like a hip replacement at the age of 35. At the age of 35, most people are working, right? You will need about 3 to 4 months, if everything goes well, off work, off employment, to deal with this. 1 in 3 patients are on short-term disability within the first decade from diagnosis. 1 in 4 on long-term disability, all right, within the first decade. And try not to imagine, because if I say that, for example, for a patient with, say heart disease, with a heart attack, and the patient is 60 years old, the patient will be on disability by the age of 70. Most likely he will get his pension by 65. Our patients start from the age of 30 or 25 or even like younger ages. So we're talking about like very young patients who will be out of the market, out of work, actually from the age like of 40. I want to say a few things about social barriers, and I will thank a patient of mine, Kirisa Sellers. Is a wonderful person. She's a patient of mine from the very beginning when I started like practicing in Hamilton, and she emailed me yesterday with her thoughts about this. Sometimes, you know, we see you like every 3 or 4 months. We develop a relationship that is beyond this patient-doctor, the typical patient-doctor relationship. Sometimes you talk about kids. Sometimes you talk about your worries about the future and all these things. So she said, and this comes from a patient actually, and so I think it's most important, right? It doesn't come from me. Unpredictability of symptoms and fluctuation of disease activity. Invisible symptoms like fatigue, for example. I have many patients, they tell me, Doc, I wake up in the morning, I'm taking a shower, and there are days that I cannot do anything. I'll go back to bed. Right? Have I felt this at any time in my life? No. I'm jumping out of bed and I'm going to the hospital. And I'm happy for this, but I'm thinking about like how my patients really feel. Like I'm seeing them and they look great, right? And like all of you, At some point, you look great, but you had symptoms. You had this fatigue feeling that we haven't researched accordingly. This anxiety and depression, Dr. Tuma's work from the Toronto Western Clinic, we're talking about 40 to 50% of our patients with anxiety and depression. And of course, this lack of awareness, not from the government or from the mayor or anything. I don't care about this, but I care about lack of awareness from family members, from friends, from co-workers, colleagues, and lack of understanding of what a lupus patient is going through. And this, of course, will have a huge impact on relationships, being like family relationships or professional relationships or romantic relationships, I don't know, whatever relationships we develop as human beings. And of course, impact on employment. And this goes to the cost I was talking about before. Right, this comes from the UK. Barriers to maintaining employment. Almost 400 lupus patients, and they identified 3 different themes, actually, that the patients came from the patients. The first were difficulties of working and the fear of career damage with lupus. And this comes straight from responders, right? Responder 185, for example, here says, I've had to leave frontline clinical work. She was a doctor. Really hard decision to make, depressed. And the other patient here, it's an invisible illness. You will always have colleagues that don't believe what they can't see, right? We're saying like seeing is believing. Yeah. Unfortunately, they may be in a position to make decisions about your employment conditions, environment, without full knowledge of the facts. And I have, like in my personal experience, my practice, patients who had trouble. I had a patient, I'm trying to get the new medications for her with discoid lupus, anyway, a form of skin lupus. Unfortunately, this thing affected her upper lip. And her upper lip is all inflamed and painful and swollen. And her employer fired her. She was a receptionist in a hotel up north. Anyway, she was fired until she will get better. This is what her employer said. What was the second theme, actually? Fear and anxiety that overshadows work and family life. So it's not only like professional life, you also have a family, right? And you have to do things for them as well. Many of you were like young mothers when you were diagnosed with the disease, or you were diagnosed before and then you had your babies and everything. So this responder here says, I've developed an overwhelming anxiety related to employment, large gaps in my employment history due to time off I had to take to manage my health, scared to explain this to the potential employer, as well as the fact that I have lupus, because I feel that they won't employ me due to reliability, right? It's like, who of the employers will employ a patient, a person who might get like time off every so often, who will ask time for medical appointments, who will ask time to go to the labs or anything like this. This has happened in the past. I feel that people do not believe my limitations because of my age and outward appearance, the invisible symptoms we were talking about. Then another responder, a loss of independence. That's a huge statement, right? A loss of independence. This is what we fear. I have to rely on my partner to pay for things I used to pay for. I can't progress in my role and earn more money per hour, as it would require greater flexibility with my shift patterns, and this would have an adverse reaction for my health. And then what they suggested, actually, the same patients actually came to a suggestion, and they said the potential of some of full-time employment when modifications of work pattern and support from management and colleagues were available. What happened? I have been very lucky, responder 26 says, in that my employer has worked with occupational health to come up with a working week that lessens the impact lupus has and are very good with time off for hospital appointments. My immediate boss has a copy of the Lupus UK Guide for Employers and is very understanding. So what's happening? Like, I didn't know about this Lupus UK Guide for Employers. This is what the patients in the UK did, right? When an employee has lupus and employer's guide, it's a 26-page booklet, actually. And this is the link for, I hope that you can use it and take a look. Actually, this is like not a bylaw or something, but anyway, something for the employers to get to be aware, to become aware of what lupus means and how lupus impacts their employees. Right, and I think that this is huge. I haven't seen anything from like in Canada, and I would very much like to develop something like this. We might be working together for something like that. A few things only, and I'm done. From the physician's perspective, this is what the physician said in the 2009 Canada survey. Language barrier, all of them, we're talking about 5 to 6%, not huge numbers. Language barrier, I really don't know how big of a problem is this. I have patients from the Arab countries here, for example, like Syrian refugees. I don't know how, but I ended up seeing like most of them, somehow they trust me. They feel like I'm from a country close by, and they feel like I'm closer to them. But anyway, most of them don't speak English, like it's like worse than mine, if you can imagine. And I'm using like Google Translate. For that, like I'm typing something, they read it, they respond, yes, no, we go with yes, no questions, okay, not ideal communication, nevertheless, better than nothing. Missed visits, non-attendance, it's an issue. It's an issue for lupus patients. They don't show up in about 5 to 6% of the cases. This is like based on our studies. What can we do? What am I doing for this? I'm trying to call them. And like, hey, how have you been? What's happening? You're good. What's happening with your medications? You have your refills, stuff like this. Even like 5 minutes will be enough for me to understand where we stand. And most of them will come, like say, like in a week or two, they will like show up to get this going. Access to medications as well, 4.4%, if I'm not mistaken, based on the physicians that were surveyed. And of course, non-adherence to medications, huge problem in the lupus community. About 43 to 75% of the lupus patients will stop taking the medications at some point during the disease course. We don't know the point exactly. It might be like after 1 year or after 10 years. What are the patients saying? What are you saying to me? What I'm getting? Doc, I'm like sick of being sick. I've been taking medicines all my life. I've been taking medicines for 20 years, right? I'm done. And they stop this. Most of them will flare. And this is happening quite a lot. Is it expected? It's expected. It's expected. These are the number of medicines, of pills, actually, that I will prescribe and any other lupologist will prescribe to a patient with a newly diagnosed lupus nephritis. So you will come to me on Monday, and on Sunday, you were taking no medicines, you were seeing no doctors, you were like super healthy and everything. And on Monday, I'll give you a prescription for 30 different pills to get every day. For the rest of your life, not for the rest of your life, but anyway, like we'll be able to go down with most of them. But yes, you will be taking something for a really, really, really long time. And we know, for example, this is like a really a very significant factor for bad outcomes, really bad outcomes. For example, 40% of lupus nephritis patients who will go to end-stage renal disease are non-compliant. And this is self-reported from the patients, right? So if they self-report 40%, the truth is most likely to 50 to or 60%. And I've seen this a lot in patients who achieve like early remission. So they take the medication, they do very well, they feel fantastic, then they will stop the medications because they feel that they're done with lupus. And of course, they will flare quickly and will have like bad outcomes. How will we will overcome these barriers? What's happening with the access to primary care? If we go to the beginning, to the primary care, we have like more than 47,000 family doctors in 2021, 24% up from 2011. We get more and more family doctors, and the plan is this, when it comes to health policy, actually to have as many as we can to cover the entire population. So every Canadian will have at least some doctor to talk to if anything happens. Access to rheumatology. We don't have many rheumatologists, like the CRA, the Canadian Rheumatology Association, not the revenue agency, it's totally different. The CRA talks about like the needs for more rheumatologists. So we're talking about like telemedicine, maybe particularly for patients up north, or patients who live like in remote areas in general. We haven't developed anything like this, and it's a thought. Right, lupus clinics, more lupus clinics, or somehow to train our rheumatologists in lupus more. Why I'm saying this? Like, if you come, for example, if we go to lupus nephritis, my rheumatology residents for the last 2 years saw 3 cases of active lupus nephritis for these 2 years of training. Is this enough? In my opinion, not. What I'm trying to do now, I'm trying to develop an educational program for the rheumatology residents across the country, like Canada-wide, for some special education, special training in lupus with video lectures and things like this. It's a work in progress, in the making. I hope that I will be able to deliver by the end of next year. Timely diagnosis. How we can make a timely diagnosis? Do we have like tests that we can use even at the very beginning, the very non-specific symptoms? Apart from the ANA, we don't. We know of a few things. We have some idea of what is happening with the immune system and everything. Like, I'm thinking about it from for like a few years now. And I think that we'll put something on the ground. Communication with the specialists. What can we do about this? Like, I'm thinking out loud here. I'm not saying anything. How can we enhance communication, improve communication? Like, maybe like an application or something, and the specialist will agree to have like all the lupus patients like texting them, or getting notifications from the app or whatever. I don't know. Medication and disease cost. I told you about the our part, my part, and the Lupus Ontario part with Cardiff, and the approval were very successful. Can we do anything about like the older drugs, say the hydroxychloroquine? Again, $2,000 for hydroxychloroquine, a drug that we have like for 60 years. Why? Compliance, very, very important. I don't know. I want your input for this. I think like it's very important to keep up with like improving compliance for all of you. So I will stop here. Thank you very much for your attention. And I'm looking forward to questions, suggestions, ideas, anything that can help improve, overcome all these barriers. Thank you.
Thank you so much, Dr. Celios. I think you could stop sharing your screen. Yes, we will see each other, which is wonderful. Thank you so much. It was such great information. You can see where things are connected, especially when you were giving the stats on the barriers, and that 27% report that cost of medication is such a significant barrier, but that it's 39.5% in Black patients is too, like, well connected to what Dr. Semilio's research is doing. And thank you for looking at the research in so many different areas. We have a question specifically about virtual and remote care. So how helpful are virtual and remote care options in connecting patients with a rheumatologist or a lupus clinic for care and trying to address access to this specialized care?
I think it's important. Why it's important? We have many patients up north, actually, in Ontario. I'll talk about Ontario. We have many patients up north who do not have regular access to a rheumatologist, or they have to travel to see a rheumatologist. For example, I saw a patient, seasoned nurse, up in Thunder Bay. I was begging her to come over for 2 years. And she found some time, and she flew over like a couple of weeks ago. And this is the first time I actually saw her. Right. All this happened like after like 2 years. Yes, almost 2 years. The issue is that we, in most cases, not in most cases, but if a flare is going on, we would like to see the patient in person. Is this always feasible? It's not. Like, if you're in Thunder Bay and it's like January or February, I don't know if they can even fly from that. If we can have what we say, like a video conference or like a video call, I will be able at least to see the patient, and like an experienced rheumatologist will understand what is going on. There are rheumatologists who have established this, for example, there is a clinic in Bury with video conference calls, and they can follow patients up north, and they're doing a wonderful job there. But I think that there is space for improvement, and we can maybe have this, say, in Hamilton or like in other centers, to be able to follow our patients up there. Like I don't have this now in Hamilton. And a call visit, a phone call visit is not enough, in my experience, and what we saw in the pandemic, is not enough, one, for me to understand how the patient is going. Two, for the patient to fully express the symptoms. I have seen like plenty of patients, Lisa, downplaying the symptoms during a phone call. I don't know why this is happening. They feel that they are like nagging too much. They feel that they don't have enough time to, they can't express themselves on the phone. I don't know. But I have seen this time and time again, and I left with the impression that the patient is okay, stable. And then when they came in person, like after a month or 2 months, they were like all flat. And when I asked them, actually, the response I got was, I didn't want to bother you, doc. Like, I think you're too sensitive, you're too kind, too polite. Right? The lupus community are all too polite for this.
Yeah. One of the things that I can suggest to as a lupus patient myself is, take notes for patients, as like patients themselves, take notes for yourself before you come to your appointments, even if it's a teleappointment, to remind yourself that of the days that were poor, what your symptoms really were. Keep an ongoing journal if you can, even though that in itself is exhausting, but can definitely help when you have these calls, so that you as a patient don't feel you're wasting a doctor's time, but you're able to articulate what your concerns are.
Right. There is an application actually that was developed from down the States. I don't remember the center now, like a diary, a logbook of symptoms. And then like you can have all this, you can tap this in, and then discuss this with your doctor, your next appointment. Absolutely. Something similar is developed by Dr. Fortin in Laval in Quebec. I don't know. The issue is, like I said about like the communication with the specialist, and I was thinking like, could we have like an application or a system that would get you to your specialist like on real time, say like with a notification or something, like how the physicians would take that? What would be the perception? I don't know. I discussed it with a few doctors. They didn't like the idea.
Well, future ideas, you never know, right? I'm just mindful it's just 12 o'clock now, but we did start a few minutes late, so we're about to have a break, so just bear with us for a few minutes as we just deal with a couple last questions. One of the things I wanted to ask specifically, but that does relate to that virtual and remote care, is you were indicating how important being a part of a lupus clinic is, the factors from the physician side, the level of care that we get. We know that there are 6 accredited ones across Ontario, but they are not in areas, like you said, where people may live, that a lot of people have to travel far if they can get to them. So the remote and virtual options is great where we can have it. But how can someone get to a lupus clinic if they're not currently part of one, or can they encourage their current rheumatologist to be connected to the clinics?
It's a very sensitive issue, because like rheumatologists are seeing lupus patients, are taking care of lupus patients, and I don't know how comfortable they would be to share the patients or refer the patient to a lupus clinic. Like in my limited experience, we are getting the most complicated, or anyway the sickest patients. Like when they cannot, or when the community rheumatologists don't feel that they can offer something more to the patients, or they will send the patient to the lupus clinic, because lupus clinics have access to clinical trials of medicines that are not yet approved. And this is another, I would like to stress this, like by having a lupus clinic, a lupus center, we have access to trials, like phase 3, like advanced trials. I'm not talking about the preclinical or something. Phase 3, so the drug is safe in general, and we're trying to see its efficacy. right? And we have access, our patients can have access to these trials, of course, with the possibility to get on the placebo arm based on the design of the trial. But we can have this as well. And this is another advantage of the lupus centers.
Right. That makes sense. And then one last question then from someone was, can earlier multi-targets treatment improve compliance and outcomes?
Multi-target treatment, by multi-target treatment, actually, we mean a treatment that consists of 3 or 4 different medications, maybe in lower doses, but 3 or 4. I don't know. We don't have any like data for this, but I'm thinking that if we have like 3 or 4 different medicines, that means maybe 10 or 15 pills a day. I don't know how this will help compliance. With the outcomes, we have shown that this multi-target therapy, particularly lupus nephritis, helps a lot. It exerts like better outcomes, yes.
Gotcha. That's wonderful. Well, thank you so much, Dr. Selios, for providing us the information, specifically like the barriers that you have as physicians in Canada, plus the patients, but also the advocacy that's happening to improve things. That's wonderful news going forward, and we know that we're going to look forward to improved access to care going on. Thank you so much for your time.
After the holidays, hopefully.
Yes, fingers crossed there. So yeah. Thanks to everybody. We have a break now, and the next session will start at 12:30.
Okay, thank you, Lisa. Thank you all.
Bye-bye.